This cat presented to our hospital with a history of chronic obstipation with unsuccessful treatment medically, and he's in for a subtotal colectomy. When performing a subtotal colectomy, it is important to leave approximately 1.5 to 2 centimeters of distal colon measured carefully from the pubis. This ensures that the surgeon has ample room to perform the anastomosis, yet does not increase the patient's chances of developing a recurrence of the obstipation. Local colonic blood supply is ligated, and in this particular case we're going to perform an ileocolic anastomosis. Because it's impossible to clean these patients out prior to surgery, the stool is massaged up into the descending portion of the colon and evacuated from the distal portion of the colon as best as possible. Forceps are placed on the colon, again being careful to allow 1.5 to 2 centimeters of distal colon so that the surgeon can easily perform the anastomosis. To help manage the relatively small lumen diameter of the ileum, the surgeon places hemostats at an angle so that when the ileum is incised at the angle, it will actually increase the lumen diameter by a couple of millimeters. The colon is then amputated and removed from the surgical field. Because of the contaminants left in the distal part of the colon, this area is lavaged with 0.01% betadine to limit the number of resident bacteria remaining in the lumen. You can see this being performed here. Care is taken not to let the betadine get into the peritoneal cavity. In this particular situation, we will manage lumen diameters by decreasing the size of the larger diameter, and you can see this is being done by the surgeon using a simple interrupted appositional suture pattern, and in this case we're using 3O monofilament synthetic absorbable material. Once the lumen diameters approach a similar size, the mesenteric stay suture is placed in each of the segments of intestine in order to bring the two segments in close apposition to one another. Once the ends of the intestine are in close apposition, it is easy for the surgeon to determine if the lumen diameters are similar enough that suturing the anastomosis can commence. The antimesenteric stay suture is then placed from the antimesenteric border of the ileum to the sutured commissure of the colon. This is brought in gentle apposition. The suture will remain as a stay suture and help facilitate traction and countertraction of the two intestinal segments that will in turn facilitate closure. The anastomosis is carefully performed using the 3 millimeter rule. Sutures are placed so that they get a 3 millimeter bite based on the cut edge of the serosa, and that the sutures are no further apart than 3 millimeters. And in cats, oftentimes the surgeon will elect to have sutures approach 2 millimeters apart as opposed to 3. The opposite side of the anastomosis is performed in a similar fashion. Doyen intestinal forceps are removed. The anastomosis is carefully inspected. And the mesenteric rent closed to prevent incarceration of visceral structures.